to get going today. Again, I want to welcome everybody out to our webinar series, our free webinar series with Discount Medical Supplies on how to create a chiropractic treatment plan. Please definitely check out our weekly specials on Discount Medical Supplies. We've got some great specials today that you're going to want to see for your office. And please, every week, check the free webinar section down on the bottom of our website in the Practitioner Help Center. And this webinar will be recorded. You can go back at any time within 24 hours and watch the recording under the recorded webinars from all of the consultants that are really giving their great time to help you within your practices. We will have a question and answer session at the end of this webinar, so please keep your questions until then, and then Dr. Kotlar will go ahead and answer those for you. Dr. Kotlar, you're all set?
Yes, I am. Can you hear me okay?
Perfect. Yes.
Okay, great. Well, hello, everyone. I want to thank Dr. Siegel and everybody else over at Discount Medical Supplies for inviting me to do this webinar. Today's topic is how to create chiropractic treatment plans. Before we get started, let me tell you a little bit about myself. For those of you that do not know who I am a chiropractor. I practiced for 16 years. My first 12 years in practice was chiropractic only, and then 4 years of multi-specialty, MD, DC, PT, a lot of integrated practice professionals and procedures were being performed in my practice. I am also certified in CPT coding. About 10 years ago, I started Target Coding. I'm the founder and president of the company, certified in CPT coding, certified in healthcare compliance. I write articles to many publications on chiropractic and physical medicine throughout the country. I'm a featured speaker at many national and state conventions. Those of you that are part of your state association and you're looking for a speaker on coding and documentation, let me know. Maybe we could work something out. My calendar is pretty full for the next 4 or 5 months, but maybe we can work something out in the future. I also may be able to get a sponsor, so there's no out-of-pocket cost to your state association. So that's a little bit about myself. Now let's get to the topic. Chiropractic treatment plans, and you can call it a treatment plan, you can call it a care plan, you can call it a plan of care. It really doesn't matter. They're no longer optional. When I first started practicing, I didn't create care plans for my patients. Why? I'll tell you why. First of all, nobody asked me to do them. That's number one. Number two, I wasn't taught how to do them and really didn't know what goes into creating a treatment plan. Well, times have changed. They're no longer optional. Just about every insurance company, malpractice carrier, state board does require that you create a plan for the patient. Now, this plan for the patient, this treatment plan, it all begins with the patient's very first visit to your office. Before you even see the patient should fill out a good quality health history form. Make sure it's completely filled out. Make sure every single area of that form is filled out by the patient, and the front desk assistant should not let the patient see the doctor until that form is completely filled out. And I say that for many reasons. One in particular is that when that patient fills out the form, there are certain things that the patient fills out that could help justify the services you're doing and the codes you're billing. So we'll get into that a little bit later. But once the patient fills out the good quality health history form, and there are other forms that you're going to probably have the patient fill out, like a notice of privacy practices, that's a HIPAA form. Maybe you're going to have the patient sign some sort of financial agreement, maybe a form to assign benefits. If it's a personal injury, you may have the patient fill out some other specific personal injury forms. You may have the patient fill out certain ERISA forms so you can act on behalf of the patient if there's ever an audit or there's ever an issue with the claims. Also with appeals. You may have the patient fill out certain forms that your malpractice carrier requires you to fill out. So there's a lot of forms that pretty much every office is going to have the patient fill out. Once all those forms are filled out, then as far as creating the actual plan for care, you should do 6 things. You should see them on your screen. History, exam, come up with a diagnosis, set goals for the patient, list the services you're going to render, including the clinical rationale for the services, and the schedule of care. You do those 6 things, you'll be in good shape, and you won't have to worry about missing out on any important information. These are pretty much the same things that Medicare would require you to do on an initial visit. So those are the basic things. So let's go through each one. The history. Okay, so you're basically talking to the patient. You're going to go through a few things when you're talking to the patient. Now, in some offices, the staff members do the history. Some offices, the doctor does the history, or some of you call it the consultation. And in some offices, it's a combo. The staff does the beginning, and then the doctor takes over. So what I want you to do is make sure that when you're talking to the patient and you're gathering this information, that you start to create this breadcrumb trail. That's what I call it. So the history is the first breadcrumb you're dropping down. Now you do an exam, and that exam is the next breadcrumb that you're dropping down, and they should all relate to each other. It should all be like pieces of the puzzle. You're setting the table here. So let's continue with the history. There are 4 levels according to the E&M guidelines. There are 4 levels of histories: a problem-focused history, expanded problem-focused history, a detailed history, comprehensive history. Well, 99203, that's a CPT code, 99203. That's the most commonly billed new patient CPT code. There are 5 codes: 99201, 02, 03, 04, and 05. So let's just talk a little bit about 99203, 203, because it's the most commonly billed new patient code. So what does that require? That requires, you see on this slide here, a detailed history. So a detailed history, what does that include? For many providers that I speak to, they're not sure exactly what entitles a detailed history. You may be doing a detailed history based on what you learned in chiropractic college. You may be doing a history based on what your friends told you. You may be doing a history based on a technique seminar you went to. Those are all very nice. However, those won't get you paid. What will get you paid is if you follow the E&M guidelines, because those are the guidelines that the insurance companies follow in order to determine whether or not to pay you. So 99203, 99203, remember that's a 0, not the letter O, requires you write down at least 1 chief complaint, 4 items from the HPI, 2 to 9 systems need to be reviewed, and 1 item from the PFSH, or the past history, family history, or social history. So let's go through each one. A chief complaint. So Mrs. Jones comes in complaining of lower back pain. There you go. That's 1 chief complaint. Next, what did I say? 4 HPIs. HPI stands for History of Present Illness. In chiropractic college, you may have been taught this as the OPQRST. Well, you need to write down 4 of those. So it's worse in the morning. Ice makes it feel better. It's sharp, throbbing pain. It's constant throughout the day. So you need 4 of those. Next, you need to review systems. Not an examination. This is a series of questions that you're asking the patient. So you might say, Mrs. Jones, any problems in the past or present with your heart or lungs? Any cardiac or respiratory problems? The patient says no. So you need to write down 2 to 9 systems were reviewed. Now here's a little heads up. If you bump up 1 level to 99204, you have to review 10 systems. Most docs are not aware of that. So be careful with that. If you're billing a 99204 or 99205, that's a comprehensive history. You need 10 systems to be reviewed. Back to 99203. So as far as the PFSH, which is the past history, family history, social history, you need to write down at least 1 of those. So please make sure you're documenting those requirements. After the history is what? Exam. Typically, it's the examination. So similar or the same headings here, or 4 levels or 4 types. Problem-focused exam is one. Number 2, an expanded problem-focused examination. Well, that would be 99202. A problem-focused exam is 99201. A detailed exam is 99203. Comprehensive exam, 99204 and 99205. So now, what is a detailed exam? Again, many of you are billing 99203, but you're not sure what is required as far as documentation goes in order to get paid. So 99203 is a detailed exam. What's a detailed exam? What does it include? Now, you might be thinking, well, okay, patient comes in, I'm just trying to be logical here. My exam includes palpating the patient's spine, maybe doing, some muscle tests, range of motion, checking for subluxation, so those are the basics, right, as far as chiropractic evaluations go. We're looking for musculoskeletal problems. But that's not enough, typically, because you're required to have 12 exam findings. Now, they don't have to be abnormal. If you do cervical range of motion on a patient and the patient has full range, no pain, that still counts as a finding even though it's totally normal. So please be aware, you have to have 12 findings. Now, if the patient, here's where it can get a little tricky. You need to know what constitutes a finding. If the patient has low back pain and you have the patient do forward flexion, lumbar flexion, and the patient has restriction and pain, and then you tell the patient, okay, bend backwards into lumbar extension, and the patient also says, ow, that hurts, so it's restricted and painful, that does not count as 2 findings. If you do cervical range of motion and foraminal compression and cervical distraction, you're doing all those things, that all counts as 1 finding. So, you need 12 findings. Initially, you may have been thinking, well, 12 findings, that's easy. It may not be showing up in your exam forms or your exam reports that you're finding 12 elements identified by a bullet according to the guidelines, or 12 findings to keep it, in plain English. So a couple of things you can do, if you palpate and you find tenderness in certain areas like the neck, the spine, and the extremities, that counts. Range of motion in the cervical and lumbar regions, that would count as 2 findings. Looking for subluxations in the neck and the trunk, there's another couple of findings. If you do range of motion in the upper extremities, there's another 2 findings if you do both upper extremities. So you want to start gathering these findings. Vital signs, 3 vital signs count as a finding. General appearance. You can provide a brief mental assessment of the patient. What would that be? A brief mental assessment? You may be thinking, wait a second, I'm a chiropractor. Why should I have to do some sort of mental or psychological assessment of the patient? Well, you don't have to, but if the patient appears to be oriented to time and place, you jot that down. That counts as a finding. So you want to gather findings: reflexes, sensation, gait and station, skin. If the patient comes in with lower back pain and you look at the skin of the lower back and it looks normal, write that down. That counts as a finding. So make sure you're gathering at least 12 findings if you're billing 99203. If you're billing 99202, which would be an expanded problem-focused exam, you would only need 6 findings. So remember, we're building a care plan. I don't want to get too caught up on coding right now. We're talking about, the main focus here is documenting a care plan. So after you do your history, after you do an exam, now what? What are you doing? You're doing decision-making. See, now comes clinical decision-making. Some people call it medical decision-making or chiropractic decision-making. I don't care what you call it. You're making decisions now based on based on the paperwork that the patient filled out, based on what the patient told you, and based on your exam. Okay, now you have all this information. Now what? Now you're going to be making decisions. It's like you come to a stop sign. Are you going to go straight? Are you going to go left? Are you going to go right? You have decisions that you make, right? Okay. So now you have to make a decision. What are you going to do with this patient? Are you going to take x-rays? Do you have an x-ray machine? If you don't have an x-ray machine, you're going to refer the patient out for films? Are you going to see the patient once a week, twice a week, daily, 3 times a week? Are you going to use ice or heat? Are you going to use electrical stim? Are you going to prescribe a TENS machine on day 1? Or are you going to wait a couple of weeks? Are you going to fit the patient for a lumbar brace on day 1? Or are you going to wait a couple of weeks? Are you going to send the patient out for an MRI right away on day 1? Or are you going to wait to see how the patient responds to your care? See, these are all things that you have to decide. As a licensed healthcare professional, you could make these decisions. That's what your license allows you to do. An unlicensed person can't make these decisions, but as a licensed healthcare professional, you can. Now, one of the most important things that you can do as a licensed healthcare professional is come up with a diagnosis. So, coming up with a diagnosis is really important. You're putting a label on this patient's body. If you're a pediatrician and you're evaluating a child, to put a label of autism is a big deal or not. Does the child have autism or not? That's a big deal. Does this child have a psychological disorder or not? That's a very heavy label to put on someone, a diagnosis. So you should be really careful when you choose a diagnosis. Now, according to Medicare, CMS, Centers for Medicare and Medicaid Services, there's a definition of medical necessity. And part of the definition of medical necessity is right here on your screen. It says the items or services being provided must be reasonable and necessary for the diagnosis that you choose for the treatment of the patient. So please make sure. You see, when I first started practicing, I was using the same diagnosis codes on everybody. It wasn't good. I'll be the first to admit, my first 6, 7 years in practice, I was winging it. I was doing things that were not correct. I was using the same diagnosis on every patient. It wasn't good. So you want to make sure you're using diagnosis codes that link to your procedure codes. You want to make sure they're extremely accurate. You want to use diagnosis codes to the highest level of specificity. ICD-9 codes are composed of 3 and 4, 5 digits. ICD-10 is coming up soon. You have a little while. October 1st, 2014. October 1st, 2014 is when ICD-10 becomes mandatory, so you have a little bit of time. But right now, concentrate on ICD-9, 3, 4, and 5 digits. Try to use 5 digits if possible. Use digits to the highest degree of specificity. So let me show you an example here. A patient comes in with an MRI. It shows a herniated disc. Now, I don't recommend you use a herniated disc or a stenosis diagnosis without an MRI. So just a little heads up on that. Patient comes in with an MRI. We see a herniated disc. Exam shows muscle spasm. The patient has pain down her leg, low back pain, sciatica, swelling of the ankle, sacroiliac and lumbar subluxations. We took x-rays. We found lumbar disc degeneration. So now it comes time to sending in the claim. If you're familiar with the 1500 form, you'll see that box 21 has room for 4. Some electronic claims software allow you to put in more than 4. So if you can, great. But if you're limited to 4, you want to put in the 4 that gives and paints the best picture for the patient. So make sure you're using high-value diagnosis codes. One way to do that is to create a diagnosis pointer form. You should see that on your screen right now. This is a form that is in a book that I strongly recommend every chiropractor have. It's the book on the best diagnosis codes to improve reimbursement. In that book is a pointer form, and this allows you to choose the codes that have the highest value, and they are based on the hierarchy, and you check these off and you give it to your staff member, and then they could enter it into your system in the order in which will get you paid the most visits. And then 12 visits later, you reevaluate the patient, and that's how you determine what the next step is going to be. You should not be using the same diagnosis codes over and over again. They should be updated as the patient improves. Okay, so we have the history, exam, the diagnosis. That's 3. A treatment plan consists of 6 things. So here's number 4, goals. Please set goals for patients. I remember, again, when I first started practicing, I never set goals for patients. Fast forward to now, present day, and there are some doctors that are still not creating goals for patients. These are clinical goals. These goals need to be specific. They need to be feasible. They need to include a time frame. You should update them as the patient is improving. So you want to get goals from talking to the patient, from the examination. For example, the patient has low back pain, and you say, okay, let's do some lumbar range of motion, and you do lumbar flexion. Normal is 90 degrees. The patient goes 40 degrees with pain. There you go. There's a baseline number from the exam. Okay, you got a baseline number from the exam. And then what's your goal? To get the patient to, I don't know, 60, 65 degrees within a few weeks. So that's, that's one way to set a goal. Patient tells you they have difficulty bending, lifting, doing yard work, so you want to create goals that are feasible, update them as the patient improves. You may want to do range of motion reports and monitor the progress and show it to the patient so they see how things are going using specific degrees. You may want to use outcome measurement forms. Outcome measurement forms are very important to use nowadays. Actually, this is required for Medicare. As of January 1st, Medicare is now requiring certain measures, quality measures, and if you don't report these quality measures, starting in a couple of years, you're going to get paid less. You're going to get deducted. You're going to get a certain amount of money deducted off your claims if you don't use functional outcome measurement forms. So here's a whole bunch of the most common ones on your screen right now. So these are going to be done about every month to monitor progress. So, Oswestry and Roland Morris, these are all standard, excellent forms. You look at an Oswestry form, for example, that, there's the standing category. There's about 10 different categories. There's one called standing category. So, it might say in the standing category, I avoid standing because it increases my pain right away. Patient may check that one. Next, it might say, I cannot stand for more than 10 minutes without increasing pain. So, patient might check that. After a few weeks, the patient might say, well, I have pain while standing, but it does not increase with time. The long-term goal would be for the patient to check on the Oswestry form, I can stand as long as I want without pain. So you want to goal objectively towards increased function. Example, increased tolerance to sitting for up to 1 hour within 4 weeks. So other examples of goals for the patient would be to reduce back pain and stiffness using pain scales from like a 9 to a 6 within 4 weeks. Increase lumbar flexion range of motion from 40 degrees to 65 degrees within 4 weeks. Increase patient's ability to sit at a computer without low back pain and stiffness from 10 minutes to 20 minutes within 4 weeks. So these are the things that you want to have in your treatment plans when you update them, and you should probably sprinkle them throughout your SOAP notes in the assessment portion of the SOAP note. That's another thing I see a lot of insurance carriers looking for. They want to see changes. You should be focusing more on changes than findings. What do I mean by that? Let's talk a little bit about SOAP notes. In your SOAP notes, most of the time, what do you have? Spasm, tenderness, subluxation, poor posture, short leg, forward head carriage, all the, spasms, swelling, misalignment, subluxations, muscle weakness, muscle spasm, tenderness. Those are the findings, and that's what the focus is on every SOAP note. Spasm, tenderness, subluxation, spasm, tenderness, subluxation. Well, insurance companies, they want to see that, but they want to see what changes are occurring. So because of your care, is the patient's spasm getting less, staying the same, or more? Because of your care, does the patient still have subluxations or not? Because of your care, does the patient have less tenderness? Because of your care, does the patient have the functional capacity to do more normal daily activities of living? That's what the insurance companies want to see. If every note looks just about the same, spasm, tenderness, subluxation on every visit, and it doesn't really show that improvement is occurring, then you're probably not going to get paid. Or if you were paid, you're going to have to give the money back. Long-term goals, examples, able to walk long distances without pain, able to sit and stand for long periods of time without pain, able to get in and out of bed without assistance, want to get the patient to be able to perform all home activities without limitations. And you can break the goals down also into subjective goals, objective goals, functional goals, and prevention goals. So subjective goal is back pain scales. Functional goal, increase ability to do yard work, increase ability to walk, increase ability to perform ADLs independently without assistance. Prevention goals, we want to initiate a home exercise program for the patient or participate in sports activities. Perform aerobic and weight training 3 to 5 days per week. These are just some examples. The next step, number 5 out of 6, is what services are you going to be rendering to the patient? What do you think is going to get this patient better in the shortest period of time? Because again, when it comes to medical necessity, the definition of medical necessity includes providing services that can be safely provided to the patient and accomplishes the desired end result in the most economical manner and in the shortest period of time. That's part of the definition of medical necessity. So what are you going to do for the first 12 visits? Just use, a month or so of the first 12 visits. Well, here's a whole bunch of choices. You're going to use ice or heat. You're going to use electrical stim, traction. By the way, many of these services here that you can do involve products and supplies, and this is where you can get the best deals by going to discountmedicalsupplies.com and looking for ice packs, hot packs, traction, DME equipment, massage lotions and oils. So, you're going to do manual therapy, massage therapy. You're going to do therapeutic exercises with the patient, or neuromuscular reeducation, or both. How about therapeutic activities? Make sure you know the difference between therapeutic exercises and therapeutic activities, and they're both time-based. Are you going to use DME, TENS, lumbar braces, cervical traction? You're going to take x-rays. Going to do any diagnostic testings like EMG, NCV. You're going to refer the patient out for a consultation. Of course, chiropractic, acupuncture, strapping, taping, casting, kinesiotaping, orthotics. That's spinal orthotics and foot orthotics. You're going to do functional evaluation on a patient. That's a different CPT code. Trigger point therapy, maybe you have a DCPT-MD set up. So you may have a MD or a DO or a nurse practitioner or a physician assistant in your practice that's doing trigger point injections. Lab work, weight loss programs are excellent, nutritional consultations, re-exams. So you have to start making decisions on what services you're going to be rendering, and then you should also be including the clinical rationale as to why you're doing these services. So if you're going to do traction, why? Well, it's used to separate and stretch the spinal segments. It's used to promote joint hydration, promote gliding of the joint facets. Those are the key buzzwords you should have in your notes if you're doing traction. For every procedure code, you should have the clinical rationale written down, or at least you know it in your head. So if you ever question, if it's an insurance case, if it's an audit, malpractice, state board issue, and your question, for example, Dr. Smith, why are you giving this patient a chiropractic adjustment? What's the clinical rationale? What's the purpose of a chiropractic adjustment? What would you say? Or what's the purpose of myofascial release? We see, doctor, you're billing 97140, myofascial release or manual therapy. What's the clinical rationale for that? Why are you doing it? And what are you doing to monitor the patient? Are you going to be doing that forever, or do you have a clinical goal and end point in sight? So please remember to think about those things. The next thing you should do, I mentioned a couple of time-based codes. So myofascial release is a time-based code. So I'm going to give you a little surprise quiz here. So according to CMS, one time-based unit is 8 to 22 minutes. 2 units is 23 to 37 minutes. 3 units is 38 to 52 minutes. 4 units is 53 minutes to 67 minutes. Okay, so that's according to CMS. Now, you may be billing certain insurance companies that don't follow these. Most do, but you may be dealing with a company, especially in-network, that says it has to be 15 minutes. So if that's the case, then you have to follow those. But most follow the 8 to 22-minute rule. So if you have a patient coming in and getting myofascial release on the lumbar region, here, look at the screen, 10 minutes of myofascial release and 10 minutes of therapeutic exercises, 5 minutes of mechanical traction, and a 3-region chiropractic adjustment. How would you bill this? Can you bill? What CPT codes would you bill for these 4 bullet points? Let me narrow it down a little bit. Can you bill for both the myofascial release and the therapeutic exercises? The answer is no, because the total amount of time is 20 minutes. Remember the 8 to 22-minute rule. So you have 2 services, total those up, that's 20 minutes. You couldn't bill both. You'd have to pick one or the other. And then for the traction, which is not a time code, it's 97012 and 98941. So again, for those 4 bullet points, you're going to bill 97140 or 97110. You can pick either one because the amount of time is the same for both, 10 minutes each, but you only got into 20 minutes. 2 units or 2 codes begins at 23 minutes. So 97140 or 97110, and then 97012 for the traction, and then 98941, which is the 3 to 4 region chiropractic adjustment. So I wanted to give you a little update on a little bit on time codes because I did mention it. Next, the schedule of care. The schedule of care. This is very important. I've seen some insurance companies deny payment because the doctor didn't have a schedule of care. Now, the schedule of care is not your entire treatment plan. The schedule of care is not 3 times a week, forever. The schedule of care includes frequency and duration. So it could be as simple as this. You should see it on your screen. 3 times a week for 4 weeks. So 3 times a week is the frequency, 4 weeks is the duration, and then you're going to reevaluate. Now, you may want to mention if the patient doesn't respond in a certain amount of time, you're going to recommend an MRI or an NCV or an EMG, and you know what you anticipate. So that's the basics. Now, if you wanted to add some optional information like, you know, the patient's problem is recurrent and chronic, they've existed for prolonged periods of time, and fibrotic tissue has developed, you know, so that gives the carrier an inkling that this is going on for a while. You may want to put in something like this. This is more of a malpractice risk management item. You can put in something like the diagnosis, the prognosis, the care plan, alternative care options, risks and benefits were explained to the patient. The patient was given the opportunity to ask questions. The patient consented to begin care. You may have a written informed consent. So that wraps it up for the 6 basic items that you would need to create a care plan, and then you start treating the patient. After 6, 8, 10, 12 visits, something like that, around there, you're going to reevaluate the patient. And what are you going to do? You're pretty much going to do the same thing again. You're going to get an updated history. You're going to get an updated exam, updated history. So you might say, you know, patient came in for a reevaluation today. Patient has made improvement. You're going to get an updated exam, updated diagnosis. So maybe you had 10 diagnosis codes on the initial visit, and now you have 6 or 5. So that shows the patient's getting better. You're going to have updated goals, updated care plan, and your updated assessment is basically going to be like this. The patient has made improvement. However, he still needs to take breaks throughout the day to rest his back and leg. Still has some difficulty doing simple daily tasks. Initially, he was not able to stand for more than 10 minutes without the pain. Now the patient can stand for 20 minutes. Patient has made significant improvement. Initially, the low back pain was a 9 out of 10, which is severe. Now it's 6 out of 10. So that's what you want to do. You want to show that the patient has improved, but they're typically not done after 1 month of care, so you have to give the reasons why the patient's not done. You want to set new goals that you're striving to reach. Maybe you're going to switch from ice to heat, from electrical stim to ultrasound, from passive to active care. So that's what happens during the reevaluation. You're going to come up with a new game plan. All right, so a few closing comments. You must check with all the carriers you bill prior to submitting claims based on the information in this presentation. We don't guarantee that the information provided in this presentation is going to guarantee payment from any insurance company or patient. We're not responsible for any rules, laws, or guidelines that may change following this presentation. Please understand that these rules and medical policies, they can change. They change all the time. So it's important for you to do your best to stay on top of these changes by attending seminars and webinars like this that Discount Medical Supplies offers, which are amazing and very good quality webinars. So attending these and joining your national and state professional associations.